noticed whenever you start doing anything new, it seems so difficult in the beginning? It feels as if it is just not coming and you are not at all enjoying it. Yes, so when you start enjoying doing something, that is what is known as a state of flow. And for the state of flow to occur, there are two things which is necessary: the difficulty level and the expertise. Both of them should match each other, which means that yes, initially your expertise will be less and the difficulty level will be more. So yes, it will not be easy, but it will become easy as you go on raising your expertise. The difficulty level will go down and you will feel as if everything is just flowing. You're just enjoying everything. So yes, if you're finding it difficult in the beginning, don't panic, don't worry. It is bound to happen. What you need to do is don't give up. Continue with infinite energy, infinite enthusiasm, infinite daring, and infinite patience. Yes, till you reach that difficulty level and you feel everything is so easy, it is just flowing. With this, we start with yet another topic of the year, a very important topic, that is acute otitis media. And here the aim will be first to understand what exactly acute otitis media is, and then to see when a patient comes to us with this complaint, which means that any presentation is given to us in the question, what are the key points that we are going to pick up and how are we going to answer these questions, how are we going to manage the patient. So what you understand by acute otitis media, and the name itself tells you that it is otitis media. It is an infection of the middle ear which has occurred acutely. So from where can any acute infection come into the middle ear? Yes, we have the connection of the middle ear to the pharynx. What is that known as? Yes, the eustachian tube, which means that if the infection comes into the middle ear, it has come from where? From the pharynx. Yes, so it is understood that the prerequisite for acute infection of the middle ear or acute otitis media is an infection in the pharynx, that is acute pharyngitis. Is that clear? Okay. So whenever a question of acute otitis media comes, yes, this is the picture that should come to your mind. So we have the pinna here, we have the external auditory canal, we have the tympanic membrane, here we have the middle ear cavity, and yes, this is the eustachian tube. So now where is the infection? Yes, the infection is in the pharynx. So the patient is having acute pharyngitis. Patient has acute pharyngitis, and this infection through the eustachian tube is going to go into the middle ear, which means that the most common organism causing acute otitis media will be the same that causes acute pharyngitis. So can you tell me what's the most common organism causing acute pharyngitis? Yes, most commonly, be it pharyngitis, be it sinusitis, be it otitis media, it is viral. Yes, but most commonly it gets superimposed with bacteria also. Yes, so the most common bacteria, if the bacterial superinfection has occurred, which usually occurs, so the most common bacteria causing acute otitis media will be Streptococcus pneumoniae. Streptococcus pneumoniae, also known as pneumococcus. So now this infection of the pharynx will go through the eustachian tube into the middle ear. So can you tell me what is the most common route of infection? Yes, so the most common route is the eustachian tube. Most common route is eustachian tube. Okay, so now let us see what the stages will happen when the infection through the pharynx goes into the middle ear. So what are the stages of acute otitis media? So first what will happen is that the infection from the pharynx will go into the eustachian tube. So when the infection goes into the eustachian tube, what will happen in the eustachian tube? There will be edema of the eustachian tube, and because of edema, the eustachian tube will get blocked. So this is the first stage, and this is known as stage of eustachian tube obstruction. This is known as stage of eustachian tube obstruction. So here the patient will come with the complaint of what? Yes, just a blocked feeling in the ear. Maybe when you see the tympanic membrane of this patient, it will be a little retracted. Eustachian tube obstruction leads to what tympanic membrane? Yes, retracted tympanic membrane. So tympanic membrane will be a little retracted. Now where will the infection go next? It will go into the middle ear. It will travel into the middle ear. Now what will happen because of infection in the middle ear is exactly the same. What happens because of infection anywhere else? What happens? Yes, there is congestion, increased vascularity. So here all the vascularity of the middle ear mucosa will increase, which means that all the mucosa of the middle ear will be hyperemic. The middle ear mucosa will be congested. So when you are seeing through the external auditory canal, are you able to see this congested and hyperemic mucosa of the roof of the middle ear? No. Of the medial wall? No. Of the floor? No. What are you able to see? We are able to see the tympanic membrane. So what will be the appearance of tympanic membrane? Yes, the tympanic membrane will appear very red, hyperemic, and this tympanic membrane appearance is diagnostic of acute otitis media. So when you see a patient who has come with pain and you are seeing the tympanic membrane, this appearance, immediately you know this has to be a increased vascularity, a hyperemic, a congested tympanic membrane. This has to be acute otitis media, and this typical appearance of tympanic membrane is what is known as cartwheel appearance. Yes, why cartwheel? Can you see that the vessels of the tympanic membrane then run radially? So because of hyperemia, it appears like a cartwheel. This is known as cartwheel tympanic membrane. So this is the second stage, and this is what is known as stage of hyperemia. And here what you see is a cartwheel tympanic membrane, red congested tympanic membrane. Now what will happen also in the hyperemic stage is, because of hyperemia, because of increased vascularity, in the middle ear will be exudation of fluid. So all the middle ear will get filled with fluid. So that is why this stage is also known as stage of presuppuration. This is known as presuppuration. Why presuppuration? Because now material for suppuration, material for pus formation is getting collected. So now what will happen next? The fluid that is collected in the middle ear will get infected, it will get converted into pus, and more of hyperemia, more and more of exudation, more and more of pus is getting formed. So now the middle ear is completely filled with pus. This is what is known as stage of suppuration. Now what will happen? More and more of pus is getting formed. Can it come out through the eustachian tube? No, because the eustachian tube is blocked. So where will it go? Yes, it will start applying pressure on the tympanic membrane. Tympanic membrane will start bulging. It will apply more pressure. Tympanic membrane will bulge more. It will start applying more pressure, and the tympanic membrane will now rupture, and all the pus will come out. Yes, so this stage where the pus forms is what is known as stage of suppuration. That is the third stage, stage of suppuration. So now when the pus comes out, usually the perforation that occurs is a small perforation, and the pus that has collected behind this tympanic membrane is huge. So the moment the perforation occurs, all the pus tries to come out through this perforation, and it appears as if the pus is pulsating out. This is what is known as pulsatile otorrhea, also known as lighthouse sign. So this is known as, in the suppuration stage, is known as pulsatile otorrhea. Pulsatile otorrhea, also known as lighthouse sign. Lighthouse sign. So here is a patient who has come to you, a child or maybe an adult who has come to you with a complaint of severe pain in the ear, and yes, this patient might be giving you the history that maybe 2 days back I had infection of the throat, and since last night or maybe today morning I am having very severe pain in the ear. So this history tells you that yes, this can be infection of the pharynx which has traveled to the ear, and now you want to confirm. You have a look at the tympanic membrane of the patient, and yes, what appearance you see is appearance like this, and this confirms that this is the patient of acute otitis media. Tell me, how will you manage this patient? Yes, what? Antibiotics? Very good. Yes, you will give antibiotics. Yes, you must be thinking it is viral most commonly. Yes, but usually when it is viral, the pain is not so much that the patient will come. Maybe it is on and off little, so usually patients do not come. When the patients have come and this is the appearance that you are seeing, it is definitely a bacterial infection. Yes, and now superinfection of bacteria has occurred, so now you have to give antibiotic against which organism? Streptococcus pneumoniae. So you will give antibiotics. You will give decongestants. Why decongestants? Yes, to relieve the edema of the eustachian tube. So you will give decongestants, and you will give analgesics. Okay. So now here is a patient who has come to you with severe pain in the ear, and when you examine the ear, you see that the tympanic membrane is red with slight bulge. Slight bulge is there. Why is the tympanic membrane bulging? Because of pus in the middle ear. Yes, so what will you do? What will you do? Okay, let me ask you another question. Another scene that here the patient has come to you with pain, and when you examine, what you see is a tympanic membrane which is congested, full and bulging, severe bulge. Just see here, it is like this. Now what? Okay, so whenever there is pus anywhere, what do? Pus anywhere, we have to drain it. Yes, so in this case, to drain the pus from the middle ear, what will you have to do? You will have to give an incision on the tympanic membrane. That is how you drain. You do incision and drainage. So when you have to drain the pus from the middle ear, you have to give an incision on the tympanic membrane. That surgery will be known as, tympanic membrane is known as Meyering. Making an opening on the Meyering is Meyeringotomy. Now come to the previous case. Yes, where the tympanic membrane was red, congested, but slight bulge. Will you go for Meyeringotomy there also? Yes or no? Just think of it. Acute otitis media is such a common condition. Anytime you have pharyngitis and by chance the infection goes into the ear, and when you go and show to the doctor says that the tympanic membrane is little bulging. Let me give an incision on the tympanic membrane. Is it okay? No. Why? Give antibiotic. Give antibiotic and it might resolve. Yes, so slight bulge also, give antibiotic, it will resolve. Then why not give antibiotic in this case also and see it might resolve when it is full and bulging? Why? Because this full and bulging is an impending rupture. Impending rupture means in spite of, even if you start the antibiotic, it is definitely going to rupture. So that is what you are also going to do now. You are going to give the incision and you are making the tympanic membrane rupture. So why not let it rupture by itself and let the pus come out? Why you will go and give an incision? Now, if the tympanic membrane ruptures by itself, then it is usually an irregular perforation. Yes, so if you give an incision, you will give a clean incision. Pus will come out and then the tympanic membrane will approximate and it will 100% heal. Whereas if it is an irregular perforation, this perforation, does it heal by itself? Yes or no? Yes, any perforation of the tympanic membrane, always remember, heals by itself. But it is no 100% guarantee that it will heal. It might heal, it might not heal. So if it does not heal, why give it a chance when you know that it is 100% going to rupture? So when you know it is definitely going to rupture, instead of it letting it rupture in a way that might not heal, what you do is you go and give a clean incision which will definitely 100% heal. So is that clear? When the patient has come to you with only a red congested tympanic membrane, there is no bulge, you give antibiotics, decongestants and analgesics. If there is a slight bulge, again the management will be the same. It will be antibiotics, decongestants and analgesics. But if it is a full and bulging tympanic membrane, if the tympanic membrane is full and bulging, that is when is impending rupture. Impending rupture. And here is when you will drain the pus from the middle ear by doing an incision and drainage, and disincision of the middle, incision and drainage of the middle ear by giving an incision on the tympanic membrane. Meyering is what is known as Meyeringotomy. Also, can you tell me the parts of the facial nerve in the middle ear? Yes. Very good. Horizontal part, that is present on which wall? Medial wall. Vertical part, that is present on which wall? Is that is present on the posterior wall. Do we see the facial nerve like a white nerve running horizontally and vertically? No, we see the bulge of the fallopian canal. The facial nerve runs in a bony canal which is known as fallopian canal. So we see the bulge of the fallopian canal going horizontally and vertically. Yes, sometimes this fallopian canal can be dehiscent. There can be this fallopian canal, bony canal can be missing in some place. In that case also what can happen is that increased pressure of the middle ear can get transmitted to the facial nerve through the dehiscence and patient can have facial nerve palsy. Also the infection, acute infection of the middle ear through the natural windows of oval window, round window, they can travel to the inner ear, they can cause complications also. So also whenever there is any patient of acute otitis media who has come to you with any complication, so why is this complication occurring in this patient? Why? Because the pus in the middle ear is exerting pressure everywhere and because of which it is involving the other areas. So again there we will go for immediate release of the pus, immediate release of the pressure of the middle ear, and that is by, yes, Meyeringotomy. So Meyeringotomy is done when there is impending rupture with or without complication. With or without complication. we will go for myringotomy. Now let us see what myringotomy is. Myringotomy, I told you, is making an incision on the tympanic membrane. Now tell me, where on the tympanic membrane will you make the incision? In other words, can you tell me which is the most accessible part of this tympanic membrane? You are standing at the external acoustic meatus. So which is the part of the tympanic membrane which is most approachable to you? Which part of tympanic membrane is more lateral, most towards the external aortic canal? Yes, we saw that the tympanic membrane is like this. Yes. So yes, this is more lateral part. That is the posterior part. So yes, we will give the incision on the posterior part. Can you tell me which tympanic membrane this is? Where is the posterior part in this tympanic membrane? Yes. So if it is marked where you give the incision in myringotomy in a patient of acute otitis media and is marked 1, 2, 3, 4. So you should know exactly which is this, which even if you know it is posterior, you should know which is the posterior part of this tympanic membrane. So what is the posterior part? I told you first thing that we see is which tympanic membrane. So yes, this is pointing towards the right. So this is the right tympanic membrane. So this is anterior and this is posterior. So yes, we will give an incision in the posterior part. Where in the posterior part? Posterior has a superior part also, inferior part also. Where? Yes, we will give an incision in the inferior part, yes. So the myringotomy incision is given in the posterior-inferior part and it is shaped like a J. It is shaped curvilinear. It is curvilinear. Why is it curvilinear? Yes, you are already seeing that the fibers of the tympanic membrane, they run radially, right? They run radially. Now, if I give a radial incision, the fibers are running radially. If I give a radial incision, will this incision ever stay open? No, it will immediately close. Yes. So how will the pus come out? It will immediately close because of the pressure. So we are giving an incision against the direction of fibers of the tympanic membrane. So that is why we give a curvilinear incision, so that once the incision is given, the pus will come out. And once the pus has come out, once the pressure of the middle ear is now normal, now the edges of the tympanic membrane will approximate and this will heal very beautifully 100% without any scarring. So now, why not superior part? Posterior has superior part also. Why not superior part? It is never in the superior part. Always remember that myringotomy is never done in the posterior-superior quadrant. Never in the posterior-superior quadrant. This is a question that is asked in your exam. Why never in the posterior-superior quadrant? Yes, do you know what are the structures in the posterior-superior quadrant? Yes, so now just have a look at this tympanic membrane. You are seeing the perforation through which you are seeing the posterior-superior quadrant. Yes, this is the anterior part. So this is the posterior-superior quadrant. Can you see all the important structures? The incus long process, the stapes, the oval window, all these, the vertical part of the facial nerve, all these are lying in the posterior-superior quadrant, because of which if you give a myringotomy, do we know that the narrowest part of the middle ear is mesotympanum? So if you are giving an incision, if you are putting the knife to give the incision for myringotomy, there are chances of injury to any of these structures, to the incus, to the stapes, to the oval window, to the facial nerve descending part. So it is never given in the posterior-superior quadrant. So is that clear now? Whenever the patient comes to you with pain and you have diagnosed him as acute otitis media, how you are going to manage? If it is just a red congested tympanic membrane, antibiotics. If it is slight bulge, again antibiotics. If it is full and bulging, then you go for a myringotomy. Yes, myringotomy in ASOM is never done in which quadrant? Posterior superior quadrant. It is done in which quadrant? In posterior inferior quadrant. What is the shape of myringotomy? Yes, it is curvilinear. It is curvilinear. Okay, so now keep your pens down. Yes, keep your pens down. Very good. Okay, so tell me, what is the most common route of infection of acute otitis media? Most common route of infection. Yes, it is eustachian tube. Most common bacteria causing acute otitis media is Streptococcus pneumoniae. What is the diagnostic appearance of tympanic membrane in acute otitis media? Very good. Cartwheel tympanic membrane, congested, red congested cartwheel tympanic membrane. If there is a bulla on the tympanic membrane, red tympanic membrane with bulla on the tympanic membrane, what is that condition? Yes, that is bullous myringitis. Don't confuse that with acute media. Acute media is a uniform bulge of whole of the tympanic membrane because of pus in the middle ear. Yes, when the tympanic membrane is full and bulging, then the management is myringotomy. Yes, what is the appearance of the pus coming out through the tympanic membrane when the tympanic membrane ruptures? Yes, it is lighthouse sign, also known as, the lighthouse sign is also known as pulsatile otorrhea, as if the otorrhea, the ear discharge, is pulsating out. So here we have this patient who has come to us with a complaint of very severe pain in the ear, and yes, he is giving us the history when elicited that he had for a few days he had totally blocked nose and pain in the throat. He was blowing his nose very hard, and probably that is the reason why maybe the infection has gone into the ear. He has come with pain. Now, whenever the patient comes to us with pain, can you rule out or can you localize where the infection is, external ear, middle ear, or inner ear? Yes, we know that if there is any pain or if there is any ear discharge, it has to be only either the external ear or the middle ear. Pain in the ear can never occur because of any condition of the inner ear. Is that clear? Neither discharge will occur because of condition of the inner ear. So now when he is telling me that he has come to me with pain, I know it is either external ear or the middle ear. So for diagnosis, I will probably just have to examine him and I will come to the diagnosis. Either external ear or middle ear. I have already told you a spot diagnosis. Yes. So what I do is, will I need any tuning fork to confirm? No, I will not. I will just have to examine him. So I will just take the otoscope, and to examine, I will take the largest speculum. This is known as ear speculum. I am going to take the largest size ear speculum which will fit his ears, and how am I going to pull the pinna? Yes, the pinna will be pulled superiorly and posteriorly. Yes, so postero-superiorly. By doing this, what am I doing? I am bringing the external auditory canal in a straight line with the cartilaginous part, the straight line with the bony part. I'm pulling the cartilaginous part up so that it becomes a straight line. So whenever I examine the left ear, I will hold the otoscope in my left hand. Yes, and so this is how I'm going to hold the pinna, and I'm going to have a look inside of to see the tympanic membrane. Okay, so now what I saw in the tympanic membrane was like this. What would I do? Yes, I will give antibiotics. Yes, decongestants. Yes, analgesics. Yes, do I need any test for diagnosing that? No, just a look at the tympanic membrane. If I saw was an appearance like this, what would I do? He's in very severe pain. Yes, in that case, I would like to go for a myringotomy. Yes, that is the OPD procedure. In the OPD itself, you can just take a myringotomy knife which appears like this. Can you see how sharp it is? Yes, so you can just take a myringotomy knife. This is a myringotomy knife, which is known as myringotome. Myringotome. So, and I can just give the incision. Where will I give the incision? Yes, where? In the tympanic membrane? Yes, in the posterior quadrant, never in posterior superior quadrant. Now, suppose if the appearance of the tympanic membrane that I saw was this. If he has come when his tympanic membrane is already ruptured, yes, many of the patients will come when the tympanic membrane is already ruptured and you can see pus in the external auditory canal. Now what? Now what? Yes, you can see the pulsatile otorrhea, the pus coming out. Yes. Now, should I call this patient for repair of the tympanic membrane? No. We know that any tympanic membrane perforation can heal by itself. If it is acute perforation, it will heal by itself. Maximum in how much time? In 3 months time. But what I have to do is I have to make this ear free of infection. So I will give antibiotics like earlier, but here the antibiotic will be not only systemic, it will be oral, that is systemic. Along with that, it will be local in the form of ear drops. So now I will give ear drops also to the patient, whereas in the earlier cases, ear drops was not required. So now I will give ear drops also to the patient, and once the ear has become dry, I will just instruct him to keep the ear dry. Keep the ear dry. He has to put a cotton whenever he takes bath. All the swimming and all that is total no-no till his tympanic membrane heals, and that will take around 3 months time. If it has not healed in 3 months time, it means that it will not heal by itself, and then you will have to repair it. But otherwise, you will have to just leave it, and it usually heals by itself. So now I think you will be able to manage any patient of ASOM, be it a clinical presentation that is given in your question, or be it a patient you know completely everything about acute otitis media. Now many a times, if the infection is more virulent, by more virulent organism, by beta hemolytic strep, yes, then the perforation that the patient has is a marginal perforation. What's a marginal perforation? Marginal perforation means that one of the margins of the annulus is eroded. Annulus is eroded, and that is when we call it as acute necrotizing otitis media. Acute necrotizing otitis media. So what we need to know in acute necrotizing otitis media is two things. First, the organism, and second, it leads to a perforation which is marginal perforation. And why is a marginal perforation important? Yes, because just see here, the marginal perforation, all this area, the annulus is eroded, so there is no epithelium here. There is no mucosal lining here. Yes, so now what will happen is this can lead to, it can predispose the epithelium from the external auditory canal to migrate into the middle ear. And when the stratified squamous epithelium from the external ear goes into the middle ear, where the stratified squamous epithelium is not supposed to be, in the middle ear, the stratified squamous epithelium is not supposed to be. The middle ear has mucosal lining, ciliated columnar, or in some places it is just columnar. Yes, in the eustachian tube area, mainly it is ciliated columnar. It has to push the secretions out. So wherever we have secretions, we have cilia. So it is usually in the middle ear we have ciliated columnar. Some places we have the columnar epithelium. We never have stratified squamous epithelium. If it migrates inside, if the stratified squamous epithelium goes inside, then that is what we call as cholesteatoma. Cholesteatoma. We will do cholesteatoma in great detail later on, but for now I'm just introducing this to you, that this cholesteatoma can be caused because of a marginal perforation, and a marginal perforation can result following which condition? Acute necrotizing otitis media. So now that I have told you that this is a marginal perforation, you must be thinking, then what was the perforation that happened in acute otitis media? We do not call it marginal, then what do we call that perforation? So let us see what are the different types of perforation of tympanic membrane. The perforation of the tympanic membrane are divided into two types. It can be either a central perforation. What's the meaning of central perforation? Central perforation means any perforation of the pars tensa, which does not involving the annulus, not eroding the annulus, not eroding the annulus. Yes, that is what is central. Yes. Now what is marginal? We'll just see in some time. Let us first see what is central perforation. Now the central perforation can be divided depending upon the site of perforation. Site of perforation means, suppose this here is the handle of Malleus, whether it is anterior to it, whether it is posterior to it, whether it is inferior to it. Yes. So if this is the handle of Malleus, what will be the anterior part? Yes. So everywhere you're seeing, you have to see which is the anterior part, which is the posterior part. So yes, we know this is the left tympanic membrane and this is the anterior part here. So if there is a perforation anterior to the handle of Malleus, we call it as anterior perforation. Posterior to it is known as posterior perforation. Inferior to it is known as inferior perforation. If there is a large perforation on the tympanic membrane involving almost whole of the tympanic membrane, leaving only a thin rim of pars tensa around, this is what is known as a subtotal perforation. So a central perforation can be either anterior, it can be posterior, it can be inferior, or it can be a subtotal perforation. Any perforation of the pars tensa not eroding the annulus is what is known as a central perforation. So now can you have a look at this image and tell me what perforation? Yes, this is asked in your question like this. What perforation of the tympanic membrane is this? Anterior, posterior? Yes. So again, what is being asked is whether you know how to know what tympanic membrane this is. So yes, this is, here this is anterior part. So yes, this is anterior. Here this is again, this is the anterior part. This perforation that we are seeing is posterior. What is this? Yes, this is a subtotal perforation. This is subtotal, only thin rim of pars tensa you can see all around. This is subtotal perforation. Now, according to the size also, the central perforation can be divided into various types. So, the tympanic membrane is divided into 4 quadrants as it is shown here by a vertical line passing at the level of the handle of Malleus and a horizontal line. So these are the 4 quadrants: antero-superior, antero-superior, antero-inferior, postero-superior and postero-inferior. So if the perforation involves only one quadrant that is known as a small. If it includes 2 quadrants, that is known as medium. If it involves 3 quadrants like this, yes, then that is large. That is large. And if it involves all the quadrants leaving only a thin rim of the pars tensa around, that is what is subtotal, that we already have seen. Yes, so now tell me, what is this perforation? Yes, this is only one quadrant that it is involving, that is small. Yes, this is medium. Can you more elaborate? This is medium and anterior posterior what? Yes, so when you write down a perforation, you have seen the tympanic membrane of a patient and you want to write down, you want to label that yes, this patient has this perforation. How do you label it? Yes, you say that this patient has a medium anterior perforation, anterior, and it is medium, anterior medium size perforation. Yes, this is a large perforation, and here what you are seeing is this is a subtotal perforation, only a small rim, thin rim of pars tensa all around involving all the 4 quadrants. So this is a subtotal perforation. Now, what is a marginal perforation? Yes, first tell me, marginal perforation follows which condition? We just saw that. Yes, it follows acute necrotizing otitis media. And what's a marginal perforation? Marginal perforation means it is involving, it is eroding any of the annulus. Any of the annulus forms a margin of the tympanic membrane. Marginal means in any of the margins, the annulus is eroded. It can be just a small area of the margin, or it can be whole, total, all the margin is involved. And also any perforation of the pars flaccida, any perforation of pars flaccida is known as marginal perforation. Why it is known as marginal perforation? Because in the pars flaccida we know that there is no annulus. There is no annulus in the pars flaccida. Yes, so any perforation of pars flaccida is marginal. Any perforation which erodes the annulus, at the margins, of tympanic membrane. Annulus is where the margin is. Yes, margins of tympanic membrane is what is known as marginal. So which means that if this perforation that you are seeing in the posterior part, the whole of the annulus is eroded, this is a posterior marginal perforation or a posterior marginal perforation. Yes, what is this? This you are seeing a perforation in the pars flaccida. So again, this is a marginal perforation. So is that very clear? Yes, so we know that whenever the perforation of the pars tensa occurs in acute otitis media, that is a central perforation. Central perforation can be either anterior, it can be posterior, inferior, it can be small, medium, large, it can be subtotal. Whatever the perforation is, that is in the pars tensa, does not involve the margins, does not involve the erode the annulus. Marginal perforation does not follow acute otitis media. It follows acute necrotizing otitis media, and that can lead to a cholesteatoma. Is that very clear? Yes, so all this is what you need to know in a patient of acute otitis media, and that is how when you see acute otitis media, when it is ruptured also, that is how you label the perforation of the tympanic membrane.